Okay, let's unpack this. We are diving into a monumental and just crucial topic today. We've got a comprehensive stack of material focused entirely on the care of the newborn.
It's a big one.
It is. And this isn't just a review, it's a deep exploration because, those first few hours and days, a human being undergoes, well, it's perhaps the most radical, simultaneous physiological shift of their entire life.
That's absolutely right. I think the mission today is to give you a shortcut, really. An expert understanding of these core newborn care and assessment principles.
Right.
We're trying to aim beyond just, definitions. We want to get into the why and the how of this adaptation, focusing on those critical details and the clinical insights that really separate surface knowledge from genuine competence.
Yeah, we're tracing that journey from a water-based internal world where the placenta did all the heavy lifting to an air-breathing, self-regulating organism. It's a transition that it highlights both the incredible vulnerability and the immense resilience built right into our biology.
It is fascinating, and we are looking at the newborn not just as a tiny patient, but as an organism that's undergoing the most rapid and complex period of adaptation it will ever face.
Right, outside the womb.
Exactly. And this requires these fundamental shifts in nearly every single system: cardiovascular, respiratory, thermal, metabolic. So our source material today really acts as a complete guide, covering that whole process of adaptation and the detailed assessments, the crucial care protocols, feeding strategies, and, critically managing high-risk scenarios when that transition stalls.
So let's start with the immediate priority then, the cardiopulmonary system. This is the big shift, the most profound change at birth, and it involves a complete overhaul of the circulatory system. So walk us through what happens the moment that umbilical cord is clamped and the baby takes its first breath.
It is. It's massive, and it's instantaneous. So while in the womb, the fetus uses these very specific circulatory shortcuts. We call them shunts.
That's right.
Yeah, because the lungs aren't involved in gas exchange at all. These shunts are the foramen oval, which lets blood bypass the right ventricle and go straight from the right atrium to the left atrium.
Skipping the lungs.
And the ductus arteriosus, which shunts blood from the pulmonary artery directly into the aorta. Again, skipping the lungs.
So the lungs are essentially what, just offline? They need very little blood flow?
Exactly. The fetal pulmonary vascular resistance is extremely high. The vessels are all clamped down. But the moment the baby is born, that cord is cut, and those lungs inflate with air for the very first time, two huge things happen.
Right.
First, the mechanical inflation of the lungs, plus that sudden jolt of oxygen in the blood, it causes the pulmonary arterioles to just relax dramatically. Pulmonary vascular resistance drops like a stone.
So that pressure drop is the key.
It is. The pressure in the pulmonary system suddenly becomes very low, so blood naturally rushes to the lungs. This increases the pressure on the left side of the heart, and that, combined with losing the blood flow from the placenta,
Forces those shunts to close.
it forces them to functionally close. The foramen oval gets pushed shut by the pressure change, and the ductus arteriosus starts constricting in response to the rise in oxygen and the drop in certain maternal hormones. And that's it. You've completed the transition to adult-style circulation.
Wow. In just a few seconds.
In seconds. It's incredible.
So that first breath is, it's a major accomplishment. Our notes highlight this necessity of early and focused respiratory assessments right away. So what's the standard first step if the airway isn't perfectly clear?
Well, often it's a very simple targeted intervention. We use the bulb syringe.
The little blue bulb.
That's the one. We use it to suction excess mucus, but we do it mouth first, then the nose, immediately after birth.
Why mouth first?
Because if you suction the nose first, the baby might gasp, then if there's fluid in the mouth, they could aspirate it. So mouth, then nose. But it's done judiciously. You don't suction every baby automatically.
Right.
Excessive suctioning can cause what's called vagal stimulation, and that can actually drop the heart rate. But if we see copious secretions or, a compromised breathing effort, the bulb syringe is our first line of defense to physically clear that airway.
Okay, so moving from air to temperature, this is where it gets, I think, really interesting. Thermoregulation. It's such a challenge because newborns are suddenly pulled from this stable, 98.6 degree environment. Why are they so acutely vulnerable to cold?
They're vulnerable for a few key structural and physiological reasons. First, they have a relatively large surface area compared to their body mass, which just means they lose heat very, very quickly.
Like a small object cooling faster than a large one.
Exactly. They also lack the subcutaneous fat that we adults have for insulation. And critically, their central nervous system is still immature, which makes it harder for them to coordinate a rapid warming response. Our notes detail 4 essential methods of heat loss we have to guard against.
Let's break those down, because understanding them really dictates the exact protective steps that we take.
Absolutely. So first you have conduction. That's heat loss through direct contact with a cooler surface. Think a cold scale, a cold bed, even a caregiver's cold hands.
Okay, direct contact.
Then there's convection. That's heat loss to cooler ambient air currents. This is why we try to keep babies away from open doors, air vents, or any kind of draft.
Makes sense.
Third is radiation. This is heat loss to nearby cooler objects without direct contact. So if the baby is in a crib next to a cold window, they're radiating heat to that window even if they don't touch the glass.
Right, and what's the major culprit right after birth? The big one.
That is evaporation, without a doubt. This is heat loss when moisture vaporizes from the skin. A baby is born wet, right? They're covered in amniotic fluid, and that evaporation causes rapid, dramatic heat loss. It is the most significant thermal challenge in that first hour of life.
So the immediate priority is just get them dry.
Get him dry, thoroughly. It's job number 1.
And here's just a surprising fact from the source material. Newborns do not shiver when they're cold. You won't see their chin quiver. So if they can't shiver to generate heat, what mechanism do they rely on?
They rely on something called non-shivering thermogenesis, or NST. This mechanism, it's detailed in the notes, it involves the metabolism of brown fat,
Brown fat.
brown adipose tissue. It's highly vascularized, it's packed with mitochondria, and when the body metabolizes it, it generates a tremendous amount of heat without any of the muscle activity of shivering. It's incredibly efficient.
There's a catch, right?
There is. That brown fat is a finite resource. They're born with a certain amount, and once it's gone, it's gone.
And that's the clinical implication, isn't it? If they use up all their brown fat stores, what happens next?
They start to rapidly deplete their caloric reserves. They're burning through the glucose that was intended for brain function and growth. This puts them at an immediate risk for hypoglycemia, low blood sugar, and metabolic acidosis. This is why temperature stability is so intrinsically linked to metabolic stability.
Which brings us to a crucial clinical nugget, one that really guides our intervention. The best warmer is not necessarily the mechanical radiant warmer.
Correct. The first line of defense is always the simplest, the least invasive, and the most protective measure. Skin-to-skin contact with the parent.
Oh, yeah.
Skin-to-skin uses the parent's stable body temperature to warm the baby through conduction and radiation. Plus, it dramatically reduces both evaporation and convection loss. We use radiant warmers when a baby is medically unstable or needs constant medical access. But for a stable baby, these protective measures, skin to skin, wrapping them up, putting a hat on, are always prioritized.
And I imagine teaching parents the simple interventions for the reverse is just as important. So if a baby gets too warm.
Right, which can happen if they're bundled too tightly or under a warmer for too long.
The first step is just taking layers off before you start any kind of active cooling.
Exactly. It sounds so basic, but these simple steps reinforce parental involvement and they prevent unnecessary medical escalation, all while keeping that baby in what we call the thermal neutral zone, where they spend the least amount of energy just trying to stay warm.
Let's connect that thermal stress to the bloodstream. How does a newborn manage hematologic adaptation?
So fetal life requires very high hematocrit and hemoglobin levels, often much higher than adult levels, because the oxygen saturation they get through the placenta is lower than what we get from breathing room air.
Okay, so they need more red blood cells to carry what oxygen they can get.
Precisely. But after birth, oxygen delivery improves dramatically, so that sheer volume of red blood cells, the RBCs, it actually presents a new challenge.
And what is that challenge?
The challenge is bilirubin. Newborn RBCs have a shorter lifespan than adult RBCs, so they break down more rapidly, and when they do, they release hemoglobin, which is then converted into bilirubin. A high initial RBC count means a higher bilirubin load, which often overwhelms the baby's still immature liver.
And that contributes directly to jaundice.
That is the physiological link. Exactly. It connects their hematology right to that later issue.
We also look closely at wet blood cells, the WBCs. How do they signal an infection in a newborn, especially since the clinical notes say they often don't mount a classic fever response.
This is a vital difference. It's so important. An adult with an infection will often have a high fever and a really elevated WBC count. A newborn might show no fever at all.
No fever.
In fact, they might become hypothermic. Their temperature might drop. That's a huge red flag for infection in a newborn. And their WBC response is often unpredictable. Instead of a clear elevation, we might see a slight rise or a drop or just a change in the type of WBCs present. Any significant deviation is treated with extreme caution and often prompts an immediate workup for sepsis.
This leads us directly to the crucial prophylactic step regarding the risk of bleeding. Why is vitamin K administration just non-negotiable?
The risk is a clotting deficiency. A newborn's gut is sterile at birth. It doesn't have the bacteria needed to synthesize vitamin K.
And vitamin K is essential.
It's essential for the liver to produce critical clotting factors, factors 2, 7X, and X. Without that vitamin K boost, the infant is at a serious risk for what we call hemorrhagic disease of the newborn, or HDN.
What exactly does HDN entail? What does it look like?
Well, HDN can manifest in a few different ways. Classically, it's bleeding in the first 24 hours. But critically, there's a late onset HDN that can happen weeks later, and it often manifests as just devastating bleeding into the brain and intracranial hemorrhage.
Which can be catastrophic.
It can be fatal or cause lifelong neurological damage. So routine prophylactic vitamin K administration right after birth is a fundamental life-saving measure. There's really no debate on that one.
Okay, let's talk about fueling this new system, the gut and intake. What's happening with the gastrointestinal and urinary systems in these first few days?
Well, the GI system is making a monumental shift. It's going from getting this continuous, ready-made nutrient drip via the umbilical vein to intermittent, high-effort self-feeding.
Right. It's a lot of work.
It is. Initial feeding relies on strong, coordinated reflexes, the suck, the swallow, and the gag reflex. And the stomach capacity is truly tiny at first. On day 1, it's about the size of a marble or a cherry. Maybe 5 to 7 milliliters.
That small capacity is such important context for parents, isn't it? Especially those who expect the baby to gulp down ounces of milk immediately.
Absolutely. We have to manage those expectations. The first stool, which is called meconium, is dark, thick, terry, and it's essentially odorless.
And that's made up of what?
It's composed of amniotic fluid, bile, intestinal secretions, and epithelial cells that accumulated all throughout fetal life. We track its passage because it signals that the GI tract is patent and functional. And crucially, clearing out that meconium helps clear bilirubin from the body.
And what about the genitourinary system? What are the expectations for urine output?
So we're assessing the genitalia for normal formation, of course, but for urine output, the primary goal is to ensure the kidneys are working and that fluid intake is adequate. It's actually normal for the first void to happen hours after birth.
So parents shouldn't panic if there isn't a wet diaper in the first hour.
Not at all. But if a baby hasn't voided within 24 to 48 hours, then that raises a concern for potential issues. Once feeding is established, a key indicator of good hydration is a shift towards 6 to 10 wet diapers a day by day 4 or 5.
Finally, before we jump into the head-to-toe assessment details, let's talk about the brain and behavior. Why is understanding these periods of reactivity in the 6 behavioral states so crucial for care and for bonding?
This framework, it moves us past viewing the baby as just a bundle of reflexes. It helps us understand their neurobehavioral maturity. The source material describes 2 distinct periods of reactivity.
Yep.
The first period of reactivity happens right after birth. It lasts maybe 30 minutes to an hour. The baby is typically alert, wide-eyed, active. This is the prime window for bonding, for skin to skin, and for initiating that first, often highly effective breastfeed.
Then they crash, right?
They do. They enter a period of decreased responsiveness, sometimes lasting for hours, where they are very difficult to arouse or feed. Then comes the second period of reactivity, where they start to stabilize into patterns that include the 6 behavioral states.
And knowing those states is key.
It is. Knowing these states, which range from deep sleep to quiet alert to full-on crying, it allows caregivers to interpret the baby's signals correctly. For instance, the quiet alert state is when the baby is most receptive to interaction. That's the ideal time for feeding or just engaging in that focused care.
Okay, so now we move into Chapter 21, the comprehensive assessment. We've established the physiological baseline. Now we need to measure and assess maturity. How do we determine a baby's functional maturity using a gestational age assessment?
This assessment is maybe the most important predictive tool we have because gestational age really dictates the risk profile. We need to know if a baby born at 38 weeks is physically functioning like a 38-weeker or, maybe closer to a 34-weeker because of some environmental factor. The gold standard for this assessment is the Ballard score.
And the Ballard score is broken down into two main categories, right? The neuromuscular characteristics and the physical characteristics. How do these features actually correlate with maturity?
So the neuromuscular section assesses how muscle tone changes as the brain matures. For instance, a very preterm baby lies in a sort of a sprawling, flaccid posture.
Almost like they're starfished out.
Exactly. But as maturity increases, the baby develops more flexion. That's the hallmark of a term baby. They pull their limbs in tightly. We test things like arm recoil and the popliteal angle, which is the flexibility of the knee joint. A more mature baby shows brisk recoil and less flexibility.
And on the physical side, what specific features are reliable markers of being full term?
The physical maturity assessments look at features that develop late in gestation, often driven by things like fat deposition or skin keratinization. So take the skin. A premature baby has thin, almost gelatinous and translucent skin. A term baby has thicker, opaque skin. We look at ear cartilage. The more mature the baby, the stiffer the cartilage. It springs back immediately when you fold it. And maybe the most reliable marker is the sole creases on their feet. Preterm infants have very few creases. Term infants have deep creases that cover the entire sole.
The clinical notes specifically mention Lunigo, that fine, downy hair. How does that fit into the picture?
It's a classic sign. Preterm babies often have lanugo covering much of their body. As they approach term, that lanugo begins to shed. So a term baby has very little left, usually just on their shoulders, maybe some on the extremities. It's one of the many pieces that, when you put them all together, help calculate the precise gestational age we use for their care plan.
Let's move to the general head-to-toe map. Beyond physical maturity, what measurements are critical for establishing a baseline?
We have to get and compare measurements of the head circumference, the chest circumference, and the abdominal circumference. The goal is to establish that baseline and look for proportionality.
What's considered proportional?
Typically, the head circumference should be slightly larger than the chest. If there's a dramatic difference, like a head that's far too small, microcephaly, or one that's excessively large, which could be hydrocephalus or increased pressure, it immediately raises a red flag.
And the question that every single parent asks,
Yeah.
how much weight loss is too much?
So normal weight loss is expected in the first few days. It's due to fluid shifts, losing meconium, and the delay before the mother's mature milk comes in. However, we have a hard limit.
A non-negotiable one.
Non-negotiable threshold. Normal weight loss is acceptable up to 10% of the birth weight at discharge. If the weight loss exceeds 10%, it signals inadequate fluid intake or milk transfer, and that baby has to remain hospitalized for monitoring and feeding intervention.
Okay, diving into specific head assessments, what are we looking for when we're assessing those, fluid-filled areas after birth, those lumps and bumps?
We often see two common variations, and it's absolutely critical to distinguish them. First is caput succedaneum. This is a generalized swelling of the soft tissues of the scalp. It's benign, it's caused by pressure during delivery, and the swelling crosses the suture lines of the skull. It resolves very quickly.
Okay, so that's the more common, less concerning one.
Right. Cephalhematoma, however, is a collection of blood under the periosteum. Because of that, the swelling does not cross the suture lines. This is blood, not just fluid, and it can take weeks or even months to reabsorb.
And because it's old blood.
Because it's old blood breaking down, it significantly increases the risk for hyperbilirubinemia, for jaundice. We also assess the fontanelles, the soft spots. A sunken fontanelle suggests dehydration, while a tense, bulging fontanelle when the baby is calm can signal dangerously increased intracranial pressure.
Okay, moving down to the integumentary system, the skin. A critical instruction from our sources is to always look at race first when assessing skin variations.
That's essential, especially for accurately identifying things like jaundice. But let's look at birthmarks and vascular collections. How do we differentiate the ones that are purely cosmetic from those that might signal a deeper problem?
Yeah, how do you tell them apart?
We differentiate based on location, appearance, and the critical test of blanching. A common benign finding is the stork bite, or nevus simplex. These are flat, pink, blanchable patches, often on the back of the neck or eyelids. They fade.
But some vascular collections will not blanch when you press on them.
Correct. And those are the ones we worry about.
So what are those non-blanching ones?
The most concerning are port wine stains, or nevus flammeus. These are often flat and reddish-purple, and they are permanent. If a port wine stain covers the area of the trigeminal nerve on the face, it can potentially be associated with Sturt-Weber syndrome.
And that involved.
That involves vascular abnormalities inside the brain that can cause seizures or developmental delays. This requires intense neurological monitoring and potentially specialized care. It's a whole different ballgame from the benign ones that usually go away on their own.
And what about distinguishing druising from genuine cyanosis?
So bruising on the face, especially after a vacuum or forceps delivery, is a localized discoloration. It might look purplish, but it's easily differentiated from cyanosis. Cyanosis indicates a systemic lack of oxygen.
And it looks different.
It does. If we see central cyanosis, a bluish tinge on the lips, the tongue, or the mucous membranes, that is never normal and warrants immediate intervention. We have to distinguish that from acrocyanosis, which is just benign blueness of the hands and feet. That's common in the first 24 hours as their peripheral circulation gets established.
Okay, let's move to the most critical neurological distinction, I think, in the whole deep dive. Jitters versus seizures. This is the ultimate test of clinical judgment in the newborn nursery.
It absolutely is. Tremors and jitteriness, that generalized shakiness, are extremely common. They're often mediated by the brainstem and usually caused by some temporary metabolic imbalance or stress. Seizures, however, represent disorganized, rhythmic electrical discharge from the cortex, and they can cause devastating neurological injury.
So how does the caregiver perform the definitive test? How do you tell them apart?
The critical differentiation is simple and it's hands-on. If the baby is shaking, you gently grab the arm or limb that is moving and you hold it firmly.
Okay.
If the movement stops when you hold the limb, it's jitters. If the movement continues, even against your restraint, it's a seizure. Seizures are non-suppressible with gentle external restraint.
Wow. That simple physical test informs such a rapid, complex intervention. So what are the two major immediate causes of jitters that require clinical action?
The most immediate cause is hypoglycemia, low blood sugar. We consider a glucose reading under 45 milligdl to be abnormal. Hypoglycemia must be treated immediately because the baby's brain relies almost entirely on glucose.
And the intervention for that is?
It starts simply. Immediate feeding or administering a glucose gel that you rub on the inside of their cheek. If that fails, it requires escalating to an IV of dextrose.
And the second major cause is linked to maternal history.
Yes, withdrawal from prenatal drug exposure. And this includes illicit drugs, but also legal substances like nicotine and prescription medications like SSRIs.
So antidepressants can cause this.
They can. Infants experiencing neonatal abstinence syndrome, or NAS, exhibit this central nervous system hyperirritability, which often manifests as severe, persistent jitters and tremors. It's crucial to get a thorough maternal history. Did they smoke? Did they take prescription antidepressants? Because that informs the care pathway. NAS jitters require supportive care and sometimes even pharmacological intervention.
Okay, moving into ongoing care, Chapter 22 details the standard protocols. Let's address a simple yet somewhat controversial point. Bathing. Why don't we immerse babies in water immediately?
Right. The shift in practice over the last couple of decades has been toward delaying the bath, often until 12 to 24 hours after birth. And we avoid immediate immersion for two main reasons.
What are they?
First, preserving thermal stability. We just talked about how big a deal that is. Immersion rapidly causes heat loss. And second, we want to preserve the vernix caseosa.
That white, waxy substance on their skin.
Exactly. Vernix is not dirt. It is a natural antimicrobial moisturizing barrier that provides protection and even aids in wound healing. So we gently wipe off any visible blood and meconium, but we try to preserve that protective barrier.
What about safe sleep positions and general protection in the hospital?
Safe sleep protocols are mandatory education for all parents. We emphasize the back-to-sleep recommendation to reduce the risk of sudden infant death syndrome, or SIDs. Protection also involves very strict security and identification protocols, matching ID bands, electronic security tags, and stringent policies on who can handle the infant to prevent any possibility of abduction.
Next, the value of screening tests, which are just essential for catching these hidden problems early. Which three main categories are mandatory now?
So first you have the newborn screening test. This is a blood test, a heel poke, taken 24 to 48 hours after the first feed. This screens for dozens of metabolic, hematologic, and genetic disorders like PKU, hypothyroidism, and sickle cell disease.
And early detection is everything.
It's everything. It means immediate dietary or pharmacological intervention, which often prevents lifelong disability.
Okay, second is the hearing screen.
Correct. The hearing screen is crucial because unrecognized hearing loss can significantly impact language and developmental milestones down the road. It's a simple, non-invasive test that's done before discharge.
And the third, the CCHD screen for critical congenital heart disease. What is the key measurement here? What are they looking for?
So the CCHD screen uses pulse oximetry, but the real insight is in the comparison. We measure the oxygen saturation on the right hand, which is preductal, meaning it's before the ductus arteriosus, and then on a foot, which is postductal, after it. If there is a significant difference in the oxygen saturation between those two sites, or if the saturation in either limb is consistently low, it suggests a heart defect where oxygenated blood is improperly mixing. That warrants an immediate cardiac workup.
Let's discuss circumcision and foreskin care. Regardless of the choice a family makes, what is the crucial parent teaching for the uncircumcised male infant?
The key teaching, the specific instruction is this. Tell parents not to forcibly retract the foreskin.
Do not retract.
Do not. The foreskin is naturally adhered to the glands at birth, and this separation happens gradually and spontaneously over several years, often into grade school. Attempting to retract it prematurely causes trauma, tearing, and potential scarring, which can actually lead to a condition called phimosis later on.
Now, for the routine prophylactic powerhouse medications, these are standard interventions because the risks they prevent are just so devastating.
So we've already covered vitamin K for clotting deficiency. The second is erythromycin ophthalmic ointment.
The iGoop.
The iGoop, yes.
Yeah.
Its purpose is topical prophylaxis against ocular infection, specifically Neisseria gonorrhea and Chlamydia trachomatis, which can cause neonatal conjunctivitis and potentially blindness if they're acquired during passage through the birth canal.
And the third essential prophylactic involves immunization.
That's the hepatitis B vaccine. This is routinely administered as the first dose of a series to protect against hepatitis B infection. And critically, if the mother's hepatitis B status is positive or unknown, the infant receives the vaccine and hepatitis B immune globulin, or HBIG, at the same time.
Why both?
The HBIG provides immediate passive antibodies to bridge the gap until the vaccine provides active long-term immunity.
Okay, let's dedicate some serious time to bilirubin and jaundice management. This is the most common reason for hospital readmission, and it requires a really nuanced clinical understanding. So explain the normal pathway of bilirubin excretion again, but really emphasize where the problem happens.
Right. So bilirubin is the toxic waste product of red blood cell breakdown. It starts as unconjugated bilirubin. This form is fat-soluble, which means it can cross the blood-brain barrier. That's the danger.
Right.
The baby's immature liver has to convert this into conjugated bilirubin, which is water-soluble, so it can then be excreted through the stool and urine. Jaundice, that yellowing of the skin, happens when that unconjugated bilirubin builds up faster than the liver can process it.
And we have to distinguish between the common types.
Yes. Physiologic jaundice is the benign, expected kind. It appears after 24 hours of life, peaks around day 3 to 5, and then resolves. The most dangerous form is non-physiologic jaundice.
And how do you spot that?
It appears within the first 24 hours of life. That's the red flag. It often signals a pathological process like ABO incompatibility, Rh isoimmunization, sepsis, or a massive bruise like a cephalometoma. This level of bilirubin rise is rapid and potentially toxic because of the risk of kernicterus.
Kernicterus, that's the term that invokes immediate action, isn't it?
It is the devastating neurological complication. Kernicterus is permanent brain damage from unconjugated bilirubin crossing the blood-brain barrier and depositing in the basal ganglia. It can cause cerebral palsy, hearing loss, and potentially death. That is why non-physiologic jaundice is treated as a medical emergency.
So how do we treat hyperbilirubinemia?
The primary intervention is phototherapy. We place the baby under special blue lights. The light energy actually converts the unconjugated bilirubin molecules near the skin surface into structural isomers that are water-soluble.
So it bypasses the liver?
It bypasses the liver. The body can then excrete them through the kidneys and gut without needing liver conjugation. We monitor the total serum bilirubin levels closely and often use a transcutaneous bilirubin meter as a non-invasive screening tool.
It's important to connect this back to feeding, too. Our notes mention breastfeeding jaundice.
Right, and that's usually due to suboptimal milk intake in the first few days. It causes decreased stool output and therefore decreased bilirubin excretion. The treatment for that is often simply improving the latch and increasing the frequency of feeds to stimulate more stooling.
Okay, section 4. This is all about fueling growth, starting with the science of breast milk. Why is the composition of breast milk described as dynamic?
Breast milk is truly the ultimate personalized nutrition system. I mean, its composition changes throughout the day, through the stages of lactation, and even within a single feeding. The initial milk, colostrum, is this concentrated, highly yellow fluid. It's often called liquid gold.
And it's different from mature milk.
Very different. It's packed with protein, minerals, and huge quantities of antibodies, but it's low in fat and volume, which is perfect for that marble-sized stomach we talked about.
And as lactation progresses,
It shifts to mature milk, which is higher in fat, carbohydrates like lactose, and volume. But even then, it's dynamic. The milk at the beginning of a feeding, the foremilk, is thinner and higher in water and lactose. It quenches thirst. The milk at the end, the hind milk, is thicker and creamier, delivering the necessary fats and calories for growth.
how does the mother's body regulate this incredible production?
That process is called lactogenesis, and it's driven by a neurohormonal feedback loop. The primary hormone for production is prolactin, which is released when the baby sucks or milk is expressed. The hormone for ejection, or the letdown, is oxytocin.
Right.
Oxytocin causes the little muscle cells around the milk ducts to contract and push the milk forward. The key to sustained production is effective and frequent milk removal. It's a supply and demand system.
Tell us more about the infection-preventing components beyond just generalized antibodies.
The immunity delivered by breast milk is truly fascinating. It contains live, active components, including the mother's own white blood cells, like macrophages. Critically, it delivers high levels of immunoglobulin A, or IgA.
And what does IgA do?
IgA doesn't get absorbed into the baby's bloodstream. Instead, it coats the mucosal lining of the baby's gut and respiratory tract. It forms this protective shield against viruses and bacteria, significantly reducing the risk of respiratory infections, ear infections, and diarrhea.
Does the maternal diet still play a significant role in all this?
It does, though the mother's body will prioritize milk quality, often at the expense of her own nutritional status. However, to maintain the volume and to ensure high levels of certain essential fats, like DHA for brain development and fat-soluble vitamins, the mother needs consistent, high-quality caloric intake and hydration. A poor maternal diet will eventually compromise the supply and drain her own stores.
Let's describe the risks of not breastfeeding for both the infant and the mother.
For infants, not breastfeeding is associated with a statistically higher incidence of respiratory illness, acute ear infections, severe diarrhea, and an increased long-term risk for conditions like type 1 diabetes, celiac disease, and childhood obesity.
And for the mother.
For the mother, while it's not a disease, the lack of lactation is associated with slightly elevated lifetime risks for premenopausal breast cancer, ovarian cancer, and potentially type 2 diabetes and hypertension later in life.
When choosing a feeding method, what are the most important factors for the healthcare team to consider with the parents?
We have to emphasize that it is an informed choice. Factors include the mother's health. Some specific medications or infections, like active, untreated HIV in certain developed nations, are contraindications. We also have to consider the family's support structure, their work obligations, cultural practices, and any previous experiences they've had.
So nursing management is about more than just technique.
It's about comprehensive education on proper latch, positioning, and recognizing signs of adequate milk transfer, like hearing swallowing sounds and counting the number of wet and dirty diapers.
And if the choice is formula feeding, what are the crucial teaching points there?
Formula feeding requires meticulous instruction. We have to teach parents the correct preparation technique, stressing the importance of clean water and proper concentration. Using too much water dilutes the nutrients and can cause water intoxication.
And too little.
Using too little can cause constipation and hypernatremia, which is high sodium. We also educate them on the different types: cow's milk, protein-based, soy-based, or specialized hydrolysates, and how to identify and address common formula-related issues like reflux or colic.
Okay, we now turn to the critical subject of high-risk newborns, where the adaptation we described earlier fails, often due to prematurity or acquired conditions. Chapter 24 focuses on the challenges of timing. So let's start by contrasting the characteristics and complications of the preterm infant versus the term infant.
So preterm infants, defined as being born before 37 weeks, are functionally immature across nearly every system. Their characteristics include transparent, thin skin, a lack of muscle tone, which leads to that extended, flaccid posture, and significantly reduced brown fat stores.
Whereas a term infant is flexed, robust, and has opaque skin.
Exactly. And the immaturity of the preterm infant leads to complex complications, particularly in their respiratory function.
Let's detail the three main risks that result from prematurity.
First, respiratory distress syndrome, or RDS. This is the classic preterm lung complication, and it's caused by a lack of surfactant.
And surfactant is,
It's a lipoprotein that lowers the surface tension in the alveoli, the air sacs. It prevents them from collapsing fully when the baby exhales. Without enough surfactant, every single breath is hard work, and that rapidly leads to respiratory failure. Treatment includes giving them artificial surfactant and respiratory support like CPAP or ventilator.
okay, that's number one. What's the second major risk?
Second is intraventricular hemorrhage, or IVH. The blood vessels in a specific area of the premature brain, the germinal matrix, are extremely fragile. Fluctuations in blood pressure, often from respiratory distress or stress, can cause these vessels to rupture, leading to bleeding into the ventricles of the brain.
And that's graded, right?
It's graded from I to IV, with the higher grades carrying a significant risk for long-term neurological impairment.
And the third risk?
Third is retinopathy of prematurity, or ROP. This is an abnormal, disorganized growth of blood vessels in the retina, primarily seen in very preterm infants. The historical insight here is crucial. ROP is linked to the precise management of oxygen.
Too much oxygen.
Historically, yes. Too much supplemental oxygen caused this abnormal vessel growth. Modern care requires very precise, very narrow oxygen saturation targets to prevent it.
We also need to contrast the babies at the extremes of timing and size. What about late preterm and postterm infants?
The late preterm infant, born between 34 and 36 and 6/7 weeks, is often misidentified as low risk because they look so much like a term baby. But they're functionally immature. They suffer from what we call the triple threat.
The triple threat.
High risk for feeding difficulties, severe jaundice, and thermal instability. They tire easily, they feed poorly, and they can crash very quickly.
And on the other end, postterm infants.
Post-term infants, born at 42 weeks or more, face complications usually related to the placenta getting old. It starts to fail, leading to reduced oxygen and nutrient transfer. They often show signs of dry, cracked, peeling skin. They look sort of washed out. And they're at high risk for meconium aspiration syndrome because fetal distress is more common.
And comparing the size extremes, SGA versus LGA.
So SGA, small for gestational age, infants are often the result of fetal growth restriction, or FGR, because they've basically been starved in utero, they have depleted glycogen stores, and are at a very high risk for hypoglycemia right after birth.
Conversely, the LGA babies, large for gestational age.
LGA babies are frequently macrosomic, often weighing over 4,000 grams. Their primary immediate risks are birth trauma, like shoulder dystocia or a broken clavicle, and also hypoglycemia.
Why hypoglycemia for them, too?
The hypoglycemia in LGA babies, especially the infant of a diabetic mother, is caused by fetal hyperinsulinism. The baby's pancreas overproduced insulin in utero to handle the mother's high glucose, and that excess insulin remains active after birth when the continuous glucose supply is suddenly cut off.
Okay, Chapter 25 covers acquired conditions. Focusing on common respiratory problems, let's go beyond RDS and cover the three others we often encounter.
We must always be ready for neonatal resuscitation, or NRP. If the baby fails that initial transition, no respiratory effort, a low heart rate, we have structured, immediate steps. Stimulation, positioning, giving positive pressure ventilation, and if necessary, chest compressions and intubation.
Okay, what's next?
Then there is transient tachypnea of the newborn, or TTN. This is characterized by rapid, labored breathing shortly after birth. The cause is often retained fetal lung fluid and is particularly common in C-section babies who don't get that thoracic squeeze from a vaginal birth.
And it's called transient
Because it usually resolves spontaneously within 24 to 48 hours as the lungs clear that fluid.
And finally, a very serious one. Meconium aspiration syndrome.
MAS, yes. When a distressed fetus passes meconium into the amniotic fluid, they can gasp and inhale it into their lungs. Meconium causes both a mechanical obstruction and a severe chemical pneumonitis. It leads to a ventilation perfusion mismatch and often necessitates significant respiratory support.
Infections are a major vulnerability for newborns. Describe the two main ways a baby can acquire sepsis.
We categorize them by timing. Early onset sepsis occurs within the first few days of life, and it's almost always acquired during the birthing process, primarily from vaginal flora. Common culprits are group B strep and E. coli.
And late onset.
Late onset sepsis occurs after the first week. It's often acquired from the external environment, like central line infections or community exposure. Nursing care for any suspected infection is intensive. Rapid identification, which is often just a change in behavior or temperature instability, getting blood cultures, and administering broad spectrum IV antibiotics immediately.
Let's discuss specific maternal influences, starting with the infant of a diabetic mother, the IDM.
The IDM is essentially a product of an environment with excess glucose. This leads to visceromegaly, which is enlargement of their organs, and that hyperinsulinism we discussed, making immediate severe hypoglycemia the key threat. Beyond that, IDMs have a higher risk for major congenital anomalies affecting the heart, the spine, and the kidneys.
So nursing care is really focused on sugar.
It focuses intensely on blood glucose stabilization, which might require a continuous IV glucose infusion if oral feeding fails.
And the effects of maternal substance abuse, leading to neonatal abstinence syndrome, or NAS.
NAS is a painful, challenging withdrawal process. The symptoms are varied and affect multiple systems, including severe central nervous system hyperirritability. This manifests as that high-pitched, excessive crying, tremors, hypertonia, and difficulty sleeping.
And GI issues as well.
Yes, gastrointestinal symptoms like vomiting and diarrhea make nutrition very difficult. Care is comprehensive. We use scoring tools like the Finnegan score to assess severity. We minimize environmental stimulation, swaddling, dark, quiet rooms. And we often provide pharmacological treatment like morphine or methadone to slowly taper the infant off the drug. It is often a long hospital stay.
You also mentioned polycythemia as a high-risk condition, often connected to FGR or post-term status. Why does this abnormally high red blood cell count cause problems?
Polycythemia means the baby's hematocrit is above 65%. And the reason this is dangerous is that it makes the blood physically thick. We call it viscous.
Like sludge.
Exactly. This sludge-like blood flow leads to poor circulation and oxygen delivery to vital organs, increasing the risk for stroke, clotting, and kidney issues. Furthermore, since there are so many excess RBCs, their breakdown significantly exacerbates hyperbilirubinemia. Management often involves close monitoring and sometimes even a partial exchange transfusion to dilute the blood.
So what does this all mean? We've covered everything from the instantaneous life or death overhaul of the cardiovascular system and the unique metabolic demands of brown fat to the nuance of distinguishing a tremor from a seizure. We've defined the different shades of jaundice and reviewed the entire spectrum of specialized care, from routine eye ointment to managing severe RDS in a fragile preterm infant. The journey from this source material to understanding the profound vulnerability and the immense resilience of the newborn it's just truly remarkable.
If we connect this to the bigger picture, the precision that's required in newborn care, it just highlights the sheer complexity of human life beginning outside the protective environment of the womb. Every single assessment, from thermal management to the Ballard score, is a check on this highly dynamic system that's just trying to find its new equilibrium. We're essentially guiding the most rapid, complex, and profound period of human physiological adaptation.
The period of intense risk, but also, immense reward when that care is applied correctly.
This raises an important question for you to consider, though. Given the extensive list of prophylactic measures and physiological screenings we now have, as standard vitamin K, the CCHD screen, metabolic panels, we manage the physical body with remarkable efficacy. But what overlooked non-physiologic milestone, perhaps related to neurobehavioral integration or developing those early behavioral states? What is the next area we need to master to fully optimize a baby's transition to life outside the womb? Are we managing their early neurological and psychological integration with the same precision we apply to their temperature and their oxygen saturation?